All right, we're going to talk about oxygen therapy. Oxygen therapy. Oxygen is a drug. It does require a physician's order. Often in hospitals or facilities, it is a standing order. So just know that typically there is an order there already, just because if somebody needs oxygen, they don't want to waste time trying to call somebody. But it does require a physician's order. There are a lot of hazards with oxygen. Oxygen is it's flammable. This is one of the reasons that they don't allow smoking. There's a lot of reasons they don't allow smoking in hospitals, but a big reason is all the oxygen in all the walls. People on oxygen, they have to be very careful. Nothing like seeing somebody on oxygen and smoking, and you're just waiting for them to explode. Make sure you check the prescription when you have oxygen. Use humidification if it higher than 4 liters per minute. Always check the skin for pressure points. Make sure it's not being rubbed. A lot of times when people wear nasal cannulas, you need to check behind their ears to make sure it's not rubbing them behind their ear. Provide mouth care, lubricate their nostrils. Oxygen is very drying. It dries skin out, dries out the nasal mucosa. Clean the cannula, and always collaborate with your respiratory therapist. There we have good old hazards, combustionable. There's something called oxygen toxicity. It is just like anything in life. Too much oxygen is bad. Drying of the mucous membrane. Different ways to deliver oxygen, and it depends upon what the needs are, how much oxygen is needed. That's what dictates how it's going to be delivered. Low flow would be what we see the most often, would be the nasal cannula. It's comfortable, it's easy to use. Nasal cannula is 1 to 6 liters. You also have face masks. You have simple partial rebreather and a non-rebreather. Your nasal cannula, again, 1 to 6 liters per minute. Basically, if you go higher than 6 liters, you're going to have to move up to a face mask. Now you've got your simple face mask that delivers oxygen up to 40 to 60%. It's a minimum of 5 liters per minute. Make sure you have a proper fit. Again, think about those pressure points and pay attention to the skin. Partial rebreather, 60 to 75% with flow rate of 6 to 11 liters per minute. The patient rebreathes 1/3 of their exhaled tidal volume. So they're going to rebreathe some of what they have exhaled. You also have a non-rebreather, and that delivers the highest oxygen level of the low flow systems. It can deliver oxygen greater than 90%. This is used for your unstable clients that may need intubation. So this is a non-rebreather, so they are breathing that oxygen. You have high flow nasal cannulas. This is 30 liters a minute up to 60 liters a minute. Oops, and I can't go backwards. Why can't I go backwards? Shoot, it won't let me go backwards. All right, so, and then here's the Venturi mask. There's an adapter between the bottom of the mask and the O2 sources, this little adapter. And this adapter can, where you can pretty much I guess kind of like dial in how much you can set it for how much of the room air you want. So it gives a certain percentage of oxygen and room air. You have non-invasive positive pressure ventilations, which is using positive pressure to keep those alveoli open. Those are like your CPAP, your BiPAP. You have transtracheal oxygen delivery. This is long-term delivery of oxygen directly into the lungs. Here's anything with oxygen therapy. You need to set up some home care management, self-management. They need to be educated. Tracheostomy. This is you can see the incision into the trachea. It's a surgical incision to create an airway. The tracheostomy, it is basically the stoma that results from the tracheotomy. It could be temporary or permanent. Just because you've had a tracheostomy doesn't mean you're always going to. It could be temporary. With tracheostomies, you've got preoperative care, operative procedures, postoperative care. That, of course, anything postoperative, we're talking about checking for infection. You would want to make sure that that tracheostomy is clear of secretions. So here's some of the complications. You want to make sure that it's not obstructed, that the tube is not dislodged, an accidental decannulation, bleeding, infection. There's different types of tracheostomy tubes. They can be plastic or metal. These, when I was in nursing school, we were taught how to pull them out and then clean them and put them back in. Well, thank God. Now I just see disposable. I usually pull out that cannula, throw it in the trash, and pop in a new one. Here's some different examples of what these different tubes look like. And it literally, when you pull it out, it pulls right out. You throw it in the trash, pull out another one, just stick it right in. It's easy peasy. Air should be warmed and humidified. You don't want it to be, it can be very drying. Suctioning, you need to make sure that if the patient is having a lot of secretions, you'll need to suction the tracheostomy. Just remember when you're suctioning, this is what I always tell people, don't stand right in front of it because they will cough and it will come flying out. Stand off to the side. Providing the care, you also need to will need to change that bandage when it starts getting, especially that that split sponge right there. It starts getting gooky and icky. You need to change that out. A lot of times people do have these that collar, that trach collar, and it's real easy. It's kind of Velcro. You kind of undo it, and it just holds everything in place. And change out the gauze. So also with this, you want to help people ambulate. You want to turn, reposition, coughing, deep breathing, chest percussion. You want to avoid any kind of glycerin swabs or mouthwash with alcohol because you don't want to dry out their mucous membranes. Swallowing can be difficult, so you need to teach also the patient to keep their bed elevated for at least 30 minutes after eating. When they have the trach in, they cannot speak, and so they'll have to have an alternate form of communication, and that could be either a writing tablet or a picture board, flashcards. Nowadays with our smartphones, that makes things a lot easier. Support their needs, their psychosocial needs. They're going to be frustrated. They're probably going to be depressed. Talk to them in a normal tone of voice. Sometimes it seems to be like if someone cannot speak back to you immediately, you feel like they can't hear and you start raising your voice. Well, be cognizant of that and speak to them in a normal tone of voice. Weaning, they do a gradual decrease in the tube size, ultimately removing the tube. And patients should always be able to take care of their own trach. By the time they leave the hospital, they should know how to change out their trach tube themselves. They need to know that they have a shower shield. They need to increase their humidity. They need to wear a medical alert